This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, a special episode recorded on May 31st, 2024. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Today I'm back in Stockholm at the Karolinska Institute, and my guest is a professor here, Judith Bruchfeld. Welcome to TWiV.
Thank you.
Bruchfeld, is that good?
Bruchfeld is good.
Okay.
Yes.
I'm sure you have all kinds of pronunciations.
Yes, but that's
like
that's the real pronunciation,
okay.
Although I
Thank you very
use
much.
others.
So we're going to talk today about long COVID, but first I want our listeners to understand you a bit. Tell us a bit about your background and your training.
Yes. So I was born and raised in Stockholm, Sweden, but I'm half French and I have more of an international background. And I started, actually, before I started my training as a doctor, I went to Peru, to the jungle close to the Brazilian border to volunteer at a hospital that was specially designed for the indigenous population, the Shipibo Indians there. And I worked there for a year. And after that, I came home. I started to train to be a doctor. And the only thing I wanted to do was infectious diseases because I was an idealist at that time, but that sort of stayed the same during my years as a doctor. And I trained to be an infectious disease specialist, and I've been working as that here at Karolinska University Hospital, but I'm also affiliated to the Karolinska Institute as a researcher. And and then my main disease has been actually tuberculosis. So I'm a national and also international specialist in TB, but when COVID-19 hit us or the whole world, I also took an interest in what would happen with these very ill patients that we saw first as inpatients, hospitalized patients. And we decided to follow them up. We opened a specialized clinic. And then we also found out very early, actually, during the summer of 2020, that also young people that had not been hospitalized, they did not recover. So we started to follow up also that group.
And so at the same time, you're still doing TB work, right?
I'm still doing TB, but we had this clinic ongoing here. We are in Solna now, in the sort of northern parts of Stockholm. And we had research projects linked to our follow-up. So I'm not doing any clinical work. Maybe I have some questions that I answer, but now it's mainly research.
So before we talk about long COVID, when people recover from TB, do they have long-term symptoms as well?
Yes, they can have that. They can also have what we call post-TB syndrome. But TB is a very slow disease. The microbe is very slow. It replicates very slowly, and it also dies very slowly. So to be a TB doctor or TB nurse, you have to have some kind of resilience. And I think this was helpful when this new patient group came on.
Do you still have TB in Sweden, or do you?
Yes, but mainly in migrants. So
people get it elsewhere. Okay.
They've developed it here. But we also have it occasionally in Swedish people, mainly elderly people, but also young people that travel a lot to TB endemic areas.
Okay. Well, that's a topic for another podcast.
Yes.
Next time I come back,
sure,
we can talk about. I like Stockholm, so
Stockholm, and you've chose the perfect time.
This is May.
May, June is fine.
Yeah.
Yeah.
This is my second trip. I like it very much.
Yeah.
All right. So long COVID. Let's start. What is long COVID?
Well, we don't have a diagnostic test, but according to the WHO, it's a syndrome. It's a heterogeneous condition that you have acute COVID-19, but then you do not recover. And according to the WHO definition, you should have symptoms for more than 3 months after the initial disease, and they should have either been constant for at least 2 months, or you can also develop new symptoms. And that's the definition we abide by, but it's a bit problematic because the syndrome is it's like an umbrella diagnosis with a lot of different phenotypes, as we call them.
So what are some of the symptoms that someone with long COVID would have that would say you do have this syndrome?
That's a difficult question. The thing that I noticed and that we all noticed in our team, which was multidisciplinary and also multi-professional, was that the syndrome is multi-symptomatic. So I think about 200 different symptoms have been described, but common symptoms, depending a little bit on the initial condition that you had, if you were hospitalized or not, but dyspnea, fatigue, palpitations, pain, brain fog. There are a number of symptoms that are common, but that can of course occur in other diseases. So it's important to actually investigate the patient thoroughly so that they don't have something else that has to be taken care of.
So when does this occur in relation to the original acute infection? Are these symptoms immediate, or is there a delay in their appearance?
It can be both. But for example, in hospitalized patients, and that was at least in Sweden during the first wave, which was spring 2020, and then we had the second wave in the fall of 2020. Then, we didn't have any clear-cut treatment options for inpatients. We didn't have antivirals. We didn't use steroids. So mainly in our own cohort, which consists of about 1,000 patients that we follow, and about 50% have been hospitalized and the rest have been cared for at home. But if you are, for example, in intensive care and you are in a mechanical ventilator for weeks, months even, then of course you can get what we call post-intensive care syndrome, which and you can also get some, organ failures, kidney failures, fibrosis of the lungs, etc. So what we have found, but for the non-hospitalized group, usually you have quite a severe disease initially, but maybe not this very severe pneumonia, because then, you would need oxygen and maybe mechanical ventilation. But if you don't have that, you can stay at home. But these patients have also been very sick with high-grade fever, and a number of different symptoms. And some will wane, but some will on-go. And what is also very typical is that you can get new symptoms over time.
So months after the original infection,
yes, you can develop new symptoms, new conditions.
Right.
Yeah.
So is it correct to say that this happens after the virus phase is finished, when the virus has reproduced and ended? Is that then?
There's a strong hypothesis now that at least a strong hypothesis that could explain post-COVID or long COVID in the non-hospitalized group could be due to viral persistence, so that you actually do not clear the virus. In the hospitalized group, we think that there probably you have a much stronger inflammation, and probably you get rid of the virus in a more efficient way. But in the non-hospitalized group, mainly women, in hospitalized patients, mainly male patients, we think that there's a difference between these two groups, and viral persistence is probably an explanation mainly in the female long COVID patients. But this is being researched, and we will see.
So one way to address that would be to see if antivirals help those patients.
Yes, and that's what we are doing right now. We are conducting one of the first treatment trials, the first in Europe actually, where we actually treat post-COVID patients that have not been hospitalized with Paxlovid, one of the antivirals.
So is it a normal 5-day course, or is it?
No, it's 15 days, and it's a placebo-controlled, randomized, blinded study. So, and we have included now, I think by end of June, we will have included 200 patients. We have a 2-to-1 randomization, so 2 will actually get the antiviral substance, and 1 out of 3 will get placebo. But we have to give ritonavir, which is also because you can actually know if you take ritonavir, because you have dysgeusia. Yes, you have a bitter taste. So for it to be completely blinded, we have to give everybody ritonavir.
So the taste is due to ritonavir.
Yes, it is.
So what are the criteria for enrollment in this trial?
Our primary outcome measure is health-related quality of life, because we know from our own studies that health-related quality of life is very poor in the non-hospitalized patients, and over time, 2 years or more, you have a VAS scale. I don't know, EQ5D. We use that instrument, and then you have a scale from 0 to 100, and 100 is perfect health, 0 is of course terrible, but then the patient has to, or the participant has to say, today I feel, and then you set, for example, 35 out of 100. And in this group that we are including in the study, the median number is 40 out of 100, which is very bad. And in the hospitalized group, it's 65. So there's a difference. So we have that as our main primary outcome, and you should have 50 or less to be included in the study.
And then what is the endpoint for the study?
The endpoint is an improvement of at least 10 units.
I see.
So that's our primary outcome. But then we have a number of different measurements, both functional and also immunologic analysis.
So you give them a 15-day course, and then you measure to get this number scale, right? Is that how it works?
Yes, and we measure that. We have a number of different questionnaires regarding pulmonary symptoms, other symptoms, health-related quality of life. We also do cognition screening and follow-up. And the final follow-up is at 90 days. So we look at also, if there is an improvement, if it's,
Well, that'll be an interesting trial, right?
Yes, and we hope that the last last visit will be mid-October. And we actually do see improvement, but we, of course, do not know at all why. So we'll see. But there are some participants that actually feel much better and have increased their workability.
But it's such a heterogeneous syndrome that probably not everyone will respond to the same therapy, right?
Of course, it's not, we don't know if everybody has viral persistence, but what we've seen in our own study, and this is actually Peter Brodin, who is responsible for in-depth immunologic analysis, is that in this group of home-treated patients, we see that their specific antibodies towards the spike, SARS-CoV-2, is actually very high over time. But if you've had COVID-19 and you recover, usually the normal thing is that your antibody levels decrease. But in this group, it actually increases over time. And this is a preprint now that is being out for revision.
And if you do nasal swabs, they're negative?
Yeah, the virus is not there in the. It could be in the intestines. There are also some autopsy studies where you can find the virus or viral residues in quite odd. Chondrocytes in the lungs. It's hiding.
Mm-hmm. Okay.
Yeah.
So you mentioned so many of the symptoms are self-reported, but some you can test. Or you mentioned a cognitive assessment.
We can test, and we also have because we sort of set up our outpatient clinic. We didn't know what to expect at all, so we had a very broad setup of different tests, and then we noticed that, for example, some patients during a 6-minute walk test would have a very high heart rate that did not normalize at rest. And then we discovered, and we were one of the first actually to report, that some patients have developed POTS, postural orthostatic tachycardia syndrome, which COVID-19 seems to be able to induce. And this is a very difficult condition. Mainly female patients develop that, and we've also seen. And there are diagnostic criteria, for example, active standing test or a tilt test.
Table.
Yes, tilt table. Right. So this is a previously known condition that was described with criteria already in 1993. But we've also found endothelial dysfunction that we actually measure also in the study with a special device, EndoPAT. We've also found microvascular dysfunction in the heart, in the perfusion to the heart. So we've actually diagnosed quite a few sequelae that we can actually objectively assess in this group.
But that's the goal, right? To someday have a clinical measurement.
Yes, or a clinical test, like a blood sample, that would be good for the patients, because there has been a lot of questioning also in Sweden regarding, is this really something?
Sure.
Or is this female patients, and you have children and you are stressed, and But we feel quite confident that we can actually diagnose post-COVID with the methods that we have at the moment.
So you work with Swedish patients, not beyond the country, right?
No, it's Swedish patients.
Okay.
Yeah.
So let's finish the demographics. So what age and what sex mostly have this condition?
Yeah, so it's different. If you have been hospitalized, you're about 75% will be male with some kind of risk factor for severe COVID-19 pneumonia, such as diabetes, not well-controlled hypertension, overweight, and median age is about 57 years. Whereas in the non-hospitalized group, 81%, this is from our own follow-up cohort, 81% are female, median age 45, previously healthy, and not a lot of comorbidities.
Do you have any idea why you have these different?
Yeah, several. It could be that for some reason the female patients do not clear the virus, and one hypothesis is that it could be due to hormonal that there's a hormonal explanation, which I know. I mean, there are also some immune deficiencies that can explain the severe COVID-19 condition, the acute one with the pneumonia in male patients. But we'll see. We don't have a clear explanation, but hormonal changes could be one of those, because there are also female patients that have not been hospitalized that report that they have menstruation cycle aberrations, and they sometimes go into menopause much too early. So something with the virus that affects the hormone levels.
Who's the youngest? What is the youngest where you see long COVID?
Well, we only deal with adults, but the youngest that I've met was 18. Both a hospitalized patient that was actually so ill that this patient had to be in ECMO, extracorporeal membrane oxygenation, and but also young females. But this is also described in children, and there's also this tendency towards girls rather than boys.
And then the upper age is probably, there's no limit, right?
No, there's no limit, but we mainly see young females, but also some male patients that have not been hospitalized.
So that's your experience here in Sweden, right?
Yes, but it's consistent with other
Globally?
studies. Yes,
Okay.
globally.
What are the numbers like in Sweden? Like what fraction of hospitalized versus non-hospitalized end up with long
It's a very good question because we don't have any registries for long COVID, which is a problem because we don't, we had, I think we have counties in Sweden. So we have 21 counties with different systems for healthcare. But of these 21, 12 had some kind of specialized outpatient follow-up. And now there is only 3 or 4 left. And there are a number of patients that are not properly assessed. And this is maybe due to that we actually don't know the numbers because this is not reported, and we actually do not test anymore for acute COVID-19.
Yeah. But I've seen studies where it ranges from 1% to 15%.
Yes, and
Big
I
range.
think maybe the average figure is around 10% that would develop post-COVID, but then there are, of course, variations in the severity.
Yeah.
Yeah.
Does anyone fully recover?
Yeah, of course. The majority do recover after an acute COVID-19, but in this group, 10% or maybe a little bit less will not recover, and especially if you have been ill for several years. You can recover gradually. We can also alleviate some symptoms with treatment. For example, if you have POTS, we can give medication that slows down the heart rate. Some other drugs to sort of get more energy. We can also help out with the respiratory problems, both with treatment, medical treatment, and also with physiotherapy. So it's important actually that the patient is diagnosed, because then we can at least improve their well-being to a certain point. But cure is at the moment not available. And we will see with our study. We have some other options that we are also looking into now. But it's a fairly young population in reproductive age. They have worked full time, and suddenly their lives are on hold.
It's only been 3 years, more or less, right?
Yeah, 4 years, I would say.
So do you think maybe with more time, more and more people will recover? Or do you see, because you said some will never recover, so I'm wondering why.
No, we see, I am an optimistic person, so I always try to be, look at the bright side of life. But we know now that some have not recovered, and it's been 4 years since some of our patients are actually, they had their acute infection in the spring of 2020 from March to May, June. And some are still very ill.
Do most of these patients, are they unable to work?
They are unable to work. They are also unable to sort of function in their daily life with a lot of, some are actually bedridden, but they have children, they have, partners, and they are very affected by their condition.
Does vaccination status make any difference?
Yes, it actually will improve the situation. So with each vaccination up to 3, there's a Swedish study that has shown that the risk of long COVID will diminish.
Okay.
And there's also a registry study from the US Veterans Affairs Registry, Ziad Alali and his group. They also showed that if you get Paxlovid in the initial phase, the risk of long COVID diminishes, which would support the hypothesis of viral persistence in certain ways. So, yeah.
So the first infection would have the highest risk then?
No, it's not like that. That was it's a register study, but the same group has actually shown that for each infection that you get, the risk of long COVID increases. So it unfortunately you could have had COVID for 1 or 2 times. You did not develop long COVID, but the third time you will develop long COVID, and that's actually what we've also seen in our patients.
But of course, let's say if you had an infection and then had vaccination, that would decrease the risk,
yes,
right?
Yes, it would. But but then with the vaccinations, it's also before the new vaccines came that also protected against the sub-variants, Omicron variants. I've seen patients that actually had 2 COVID-19 infections, and then the third came, and then they got long COVID, unfortunately, and they were vaccinated.
But once you have long COVID, a vaccination will not help, right?
No, that has also been studied, and it doesn't help you. No. It could prevent you from getting worse if you're reinfected, because that we have seen that if you are reinfected and you have long COVID, you will have it can worsen your symptoms and your condition.
So if you have an immunodeficiency, right? So there's been many studies that show certain immunodeficiencies like interferon or antibodies to interferon, they predispose you to more severe COVID. Are they also risk factors for long COVID?
Not really, because those studies have been mainly in male patients with this very severe pneumonia.
Yeah.
And we do not see that in the female patients. They haven't had that acute variant.
Is there an immune signature that's characteristic?
Yes, this is also in the preprint by, I'm a co-author also, but by Peter Prodin and his group, where you can see that there's a CD8 T cell it's not completely, the levels are lower, so it seems like they are inhibited in some way, but not completely gone. Not exhausted. They are there, but they... And that could also be an explanation for why you don't clear the virus.
Petter also published a paper where complement seems to be involved, right?
Yes, and that was also discussed as a possible test for COVID-19, for post-COVID.
Right. Because if you have specific immune signatures, that would be the basis of a good test, right?
Yes.
Okay.
We're looking for that magic bullet.
So much of this sounds like mecfs, right? Which I'm sure you know about.
Yes, of course. Yes.
Is it the same? Is it different or similar?
I mean, it's some symptoms are similar, but I wouldn't say that it's the same. But mecfs can also occur after a viral infection. So maybe the thing is that we have a unique situation here because we have so many that had COVID-19 at the same time, and then they develop long COVID, whereas mecfs is much more difficult because they developed, they had maybe a viral infection, but it's various kinds, and often these patients are sort of going around in healthcare and are not taken seriously and misunderstood. So I think this is, maybe it will help us to understand mecfs, but I can see differences in the symptomatology, and also, I mean, COVID-19, there's a lot more problems in the lungs in our patients. Dyspnea, and also we can, see asthma seems to be something that you can develop due to in your post-COVID problems, but also that asthma could be a risk factor for actually developing post-COVID.
So I know that many of the mecfs patients feel that their onset happened after a viral infection, but it's not any specific virus. It's just...
It's probably different viruses, but I think here we have sort of a very, very distinct timeline.
Sure.
And it makes it much easier, I would say.
Yeah, as you said, you have so many people infected at once.
Yes.
And now you have this onset. You can correlate with that and makes it a lot easier.
Yes,
right?
and you also have a follow-up that is more or less the same. So, I mean, yeah.
Well, as you know, the ME/CFS has been known for quite a few years, and the patients feel they are ignored, right?
Yes, I know, I have also taken care of ME/CSF because at that time when I was a young doctor.
You're still young.
No, not very young, but anyway, I'm more experienced now. But we had an outpatient clinic for ME/CSF because the objective of that clinic, and that was also a research objective, was to see if there were residual viruses that could explain the condition, but the findings did not support that. So, but I mean, what is special about COVID-19, I would say, in the acute phase is what we saw, and I've worked for a long time as an infectious disease doctor, that it was so multi-organic. It sort of attacked all organs, and that is quite unusual, I would say. So first, the obvious thing were the lungs, but then it was, the kidneys, the brain, the thromboembolism. We were quite struck by this multi-organic involvement, and therefore it was not unreasonable to think that this would be a problem in the long term, right, that we would actually have multi-organic involvement, and unfortunately we were right in that assumption.
Many of the ME/CFS patients are very happy about long COVID because now there is attention to a different post-acute viral disease, right?
Yes, and which is also, I mean, we know that in influenza you can have, post-influenza syndrome. We also see that in, for example, tick-borne encephalitis, Lyme's disease. I mean, we know that there are a lot of viruses, and also that some actually we don't clear these viruses. They can be there and pop up when
probably every viral infection has a consequence, right?
Yes.
And we just don't see it because the numbers are small or the infections are asynchronous.
Yes,
right?
But I think COVID-19 has shed a light over ME/CSF, but also of other post-infectious syndromes that we have not been, it's not been ignored, but as you say, the numbers have been small.
Post-polio, for example.
Post-polio, that was something. When I started, my training as an infectious disease doctor, there were wards that they were abandoned, but that had been for all these iron lungs, the young patients that were in the iron lungs.
Yeah. During the COVID, that worst days, some physicians said they would like to have iron lungs because it's gentler than intubation.
Yes.
Right?
Yeah.
Because intubation can be very problematic, as you know.
Yes, of course.
Yeah. But the iron lung is gentle, but no one has iron lungs anymore.
No.
Except museums. I've seen them in museums.
Yes, yeah.
Let's see. You mentioned variants before. Do any variant have any propensity to generate long COVID, or they're all pretty much the same?
It's a bit difficult to answer because, the first waves, it looks like the Delta was at least more severe regarding this, acute pneumonia. But, and we have, the majority of our patients are from the first waves, but then we know that Omicron can cause long COVID, but then the picture is a bit blurred due to vaccination, prior infection with your own immunity. So it's a bit difficult. The maybe take-home message is that it's not over. You can still develop long COVID with the variants that are circulating now.
So we still see today long COVID rising?
Yes, that has developed at a later time point.
Right. So what kinds of therapies are you thinking about that might be useful at some point, or is it too early to know?
It's too early to know. What we'll do now when we have completed our own treatment studies, we will unblind, of course, and then we will see who has responded to what. But if we see a positive signal for Paxlovid, the first thing we'll do is to offer actually Paxlovid to the placebo group.
Right, right.
But then we have some that seem to, I don't know to what, but they seem to partially respond. You respond, but then you have a backlash during the later time points of follow-up. And some do not respond at all, but we don't know if they got placebo or something else, or maybe there is no viral persistence, or maybe the treatment length is not long enough. We chose 15 days because there was safety data up to 21 days at the time when we planned the study. So this is a phase 2 study, so we are also looking at safety.
Right. So there's often massive inflammation in COVID, right? Do you think that plays a role in long COVID as well? It can be damaging or persisting?
Yes, I think so, because it looks like the immune system is, triggered by something. And we don't know, there's been a lot of discussion regarding endothelial dysfunction, vessels that in some of our patients that are, they're young, but they have vessels like a 90-year-old, very rigid vessels that do not do their job at all with perfusion.
So have people done genome-wide association studies with long COVID patients?
No, it's ongoing, actually, through this human genetic effort where Peter Brodin is leading the long COVID subgroup. Right. So the same samples that are in this preprint is being tested now for genetic analysis together with the Belgian group and other groups. So this is ongoing at the moment. So we'll see.
So does every country have long COVID?
Yes, it has actually also in, which is interesting because also in low-income countries, it has been described. But the strange thing here in Sweden is that we don't see, migrant populations with long COVID. And I think maybe one explanation, because I'm sure that it exists, but one explanation may be that it's so difficult. You have to sort of fight your way to a specialized clinic. And you're very sick, but you still have to fight. And I'm sure that there's a number of patients that we never reach,
like with any other syndrome. But globally, do we have an estimate for how many people are affected?
Yeah, there's an old estimate that's more than 1 year old now, that there would be more than 75 million people globally and 35 million in Europe. But I think that number is underestimated. Yes.
And here in Sweden, how many?
I have no idea, but if you, because we don't even know who has acute COVID-19 since we don't test
anymore.
We have, I think, more than 2.7 million verified COVID-19 cases. So if we count 10%,
So if someone has had COVID and feels that their symptoms are persisting, what should they do?
They should go to their doctor, and hopefully they will meet a doctor who is empathetic at least, and who takes them seriously. And if they are lucky, there is a specialized outpatient clinic that could assess them. We actually, our criteria for, accepting a patient by referral, but this was only due to resources. We were working day and night with this.
Sure.
So we actually had, our one criteria was that you should have an impact on your workability, a reduction of 50%.
Okay.
Or more. So you should be quite ill.
Yeah.
But
I know in New York City, Mount Sinai has a clinic for long COVID. It has had since the very first year.
Yes.
And many people seek that out, so...
And they get appointments because we here in Stockholm we have a very long waiting list, 6 months to wait, and usually they have been sick already 1 year before they are referred.
So what did I not ask you that people need to know? Is there anything else?
No, but I think even if you don't see a doctor, a physiotherapist could be very helpful. Also, an occupational therapist is helpful. Because you can get help with, for example, if you have POTS, you have a very low resilience to standing up, then you can get things, for example, shower on a chair, you can get very helpful things in your home that can actually help you get through the day and maybe perform some chores at least, cooking, sitting down. And some of our patients even have electric wheelchairs.
Sure.
So all these professionals can actually help out. A psychologist maybe, because of course we haven't seen that our patients are more depressed than the average patient when they come initially. But of course, if you are sick for a very long time and you don't see any hope, of course, depression can occur. So anything that can help you and increase your well-being is so you should absolutely seek help. But I think it's important that knowledge of the condition, what is available, is also made available to the general practitioners and health professionals, so that you can help a patient and also guide them towards treatment that is available.
One of the problems with mecfs was that many physicians didn't believe it existed.
Yes, and that has been a problem globally, but also here. But I think it's changing now. That's what I see. That this is this is sort of an explosive research field also.
Sure.
So I think with that, why would everybody perform research if it was nothing? I think.
Right. So, I agree with that.
Yes.
So in your career, have you ever seen anything like this?
Well, I've actually experienced 4 pandemics, or not pandemics, but I'm dealing with the oldest pandemic known to man, tuberculosis, which is actually a pandemic, but sort of not a neglected pandemic. But the TB was, before COVID-19, the single infectious disease pathogen that killed the most every year, 1.5 million people. And 10 million developing disease every year. So I still think TB is very important to deal with.
Right.
But then HIV came, which of course was I was a very young doctor at the time, and I was, that was difficult, but we learned a lot, and finally we got not a cure, but at least a very good treatment. And then the SARS-CoV-2 was also SARS-CoV-1 was also, but that was very restricted. But this I must say that this may top HIV and but not TB.
I heard that many SARS-1 patients had long consequences as well. They're not as well known. Yeah.
No, but this was, that virus was not a very clever virus because it killed its host in too high percentages. Yeah, SARS-CoV-2 is much more clever.
We only had 8,000 SARS cases globally.
800 actually, 900 in total. And then we have MERS, of course. But there were a number of studies that were sort of reanalyzed and published in 2020 regarding long-term sequelae of SARS-CoV-1, follow-ups of up to 15 years, which showed quite severe sequelae.
People have been mentioning those as well.
Yes.
Yeah. It's interesting. Is there anything in common?
Yes, pulmonary sequelae, also is a more multi-symptomatic picture, multi-organic picture, which was good to know when we designed our follow-up study and clinic.
So what about MERS? Are there long-term... So some people recover from MERS,
yeah,
right?
Yes, and that has not been studied as well, but it has been described also with MERS. But also with MERS, very few cases, so it's difficult to draw any firm conclusions.
And then my last question is, we have 4 endemic common cold coronaviruses.
Yes.
Is there any... And most of these are mild, right? But
yes.
It doesn't, for long COVID, it doesn't matter if your initial infection is mild. You can still get long COVID. So do we know anything about post-acute sequelae of these common cold coronas?
No, I don't think. In immunocompetence, I
never saw that.
No, and I think we've known these viruses for so long.
Yes.
Yes, this SARS-CoV-2, it was a new virus. I had COVID-19 December 2020, and I remember that I thought this is something new. I didn't recognize all these symptoms that I had, and I also lost my smell. Yeah. But it came back, fortunately.
But it could be that some cases of mecfs occur after a common cold coronavirus infection. We don't know.
We don't know.
It's hard to make the association.
Yes. We don't know.
Okay.
It has not been studied well enough, I would say.
Okay. All right. That is a special episode on long COVID. You can find the show notes at microbe.tv/TWiV. If you have any questions or comments, TWiV@microbe.tv. If you like our work, we'd love to have your financial support. You can go to microbe.tv/contribute. My guest today from the Karolinska Institute, Judith Bruchfeld. Thank you so much for joining me and talking about long COVID today.
Thank you. My pleasure.
I'm Vincent Racaniello. You can find me at microbe.tv. I'd like to thank the American Society for Virology and the American Society for Microbiology for their support of TWiV, Ronald Jenkins for the music, and Jolene for the timestamps. You've been listening to This Week in Virology. Thanks for joining us. We'll be back next week. Another TWiV is viral.